going to talk about detecting diabetes, specifically in immigrants from African countries. And so first I want to say I don't have any disclosures, but I also want to say that although my presentation introduces clinical research findings, but should not be interpreted as clinical guidelines. I'm not a clinician, I'm a public health researcher, and so I just want to make that very clear. So I'm going to talk about what I hope to achieve today, my main messages, so that you might say, oh, wow, or you might say, oh, I've heard that before. But I'm going to talk about diabetes in African descent populations, and then I'm going to talk about 3 areas of research. One is diabetes prediction equations, like diabetes risk scores. I'm going to talk about comparing one equation to individual predictors, and then I'm going to talk about a more novel combination of non-fasting indicators of glycemia, and then I'll talk a little bit about my future plans. So today, it's my hope that whoever attends the talk will gain an understanding of the extent of the diabetes burden among Africans, and that's Africans both living in the sub-Saharan African region, but also elsewhere in the world. An understanding of the challenges of some of the current diabetes screening criteria for this population in particular. And then an understanding of what new potential diabetes screening techniques and criteria for Africans could look like. And so what am I going to tell you? Well, I'm going to tell you that in Africans, the fasting plasma glucose of 126 milligrams per deciliter or greater that we've come to believe as the true threshold and the reliable threshold for diabetes diagnosis, probably in Africans should be more along the lines of 100 milligrams per deciliter, and maybe a more effective diabetes screening tool. But I'll tell you more about how we came about that. I'm also going to tell you about that detection of diabetes among Africans could actually be improved by doing 2 things: modifying the hemoglobin A1C threshold and combining it with another non-fasting indicator of glycemia, glycated albumin. And, but before I'm going to get into the technicalities of that, I'm going to talk a little bit about diabetes in African populations and diabetes risk profiles. So the International Diabetes Federation estimates that currently, and this is an estimate, that currently about 16 million people in the sub-Saharan African continent have diabetes, but that Africa is actually slated to experience the highest anticipated increase in diabetes prevalence between 2010 and 2045. Now, this increase is quite dramatic globally, but Africa is expected to experience the most rapid increase. And so that by 2045, 41 million Africans will be living with diabetes. And this is a result of westernization, both in terms of diet, in terms of sedentary lifestyle, and other factors that contribute. It's not just diet, and I want to really emphasize that. It's also related to early life nutrition exposures, both in utero and early life. And then there are genetic factors that contribute to this risk of diabetes. There are environmental factors, and then there are transgenerational effects such as trauma or food insecurity that causes increases in diabetes risk in subsequent generations. And at this point, we have evidence that demonstrates that can manifest 3, 4, and 5 generations later. So this is a long history that we're living with. The biggest challenge in sub-Saharan Africa is that the estimate from IDF is that 70% of those living with diabetes are undiagnosed. And so if you are a diabetes practitioner in New York City, you probably are familiar with the US data that estimates that about a third of people living with diabetes are undiagnosed. So this is more than double the people living with diabetes that are undiagnosed. And again, undiagnosed diabetes leads to late detection, and often diabetes is detected once complications actually manifest, so retinopathy, neuropathy, nephropathy, and heart disease, or that people manifest with foot sores or unhealing ulcers that require surgical interventions. And so this situation really calls for sort of a reevaluation. The other thing that happens with undiagnosed diabetes globally is that there is a wide disparity and inequity in how it affects mortality and premature mortality. So right now on the African continent, it's estimated that more than 70% of the deaths that occur due to diabetes happen among people under the age of 60. So it contributes significantly to premature mortality and sort of goes against some of the gains we have made in terms of increasing life expectancy in Africa. The other challenge that the International Diabetes Federation has identified in terms of the African continent is that there is a paucity of data. And this is what I referred to in my introductory remark, that we have these systems in place that are preventing us from having being able to make informed decisions about diagnostic criteria because we have a paucity of data. And that paucity of data also affects then how we view patients of African descent when they migrate or when they live trans or international lives and move between different continents and the sub-Saharan African region. So really what we need, and this are for, to combat this epidemic, so to speak, of undiagnosed diabetes or underdiagnosis, is that we need reliable data first of all, and this goes across for other minority populations for sure. We need effective and early detection, and we need reliable diagnosis of diabetes. And so why am I talking about Africa? We're in New York City. Well, I'm talking about Africa because from the sub-Saharan African region, about 2 million, a good 2 million migrants from that region live in the United States. So main countries of origin are Nigeria, Ethiopia, Ghana, and Kenya. It depends a little bit on where we are in the US, who is the predominant population. In New York City, we have most people from Ghana, second Nigeria, etc. In Washington, DC, it's most immigrants from Ethiopia. But why this is important is that the top metropolitan destinations for sub-Saharan African immigrants in the United States are the Eastern Seaboard and primarily New York City and Washington, DC, and then Boston and Philadelphia. So the estimate is from the Migration Policy Institute that about 265,000 immigrants from Africa call our region home. And that's a good 1% of the population. In New York City, the estimate is, the official estimate, I should say, is about 77,000 sub-Saharan Africans call New York City home. I personally think the number is far greater, but I'll take the 77. So how do immigrants from African countries compare to other populations of African descent? And why are we even asking that question? So we're asking the question because once Africans arrive in the United States, they're often, if not always, categorized as African American or Black, and their unique risk profile or their unique life experiences disappear, and hence we fail to acknowledge that there is inter-ethnic variability in populations of African descent. And I'll show you with just 2 examples how what that looks like. So if we look at obesity in populations of African descent, in this graph you have on the left in the orange bar, you have the total US Black population, which at this point is probably 87% multi-generation African American. So in the total US born Blacks and US Blacks, 48% experience obesity. If you then compare with New York City data, you probably also know that we're all more slender than the rest of America, but still there's some patterns that are really interesting. So in New York City, African immigrants experience, about 21% of them experience obesity. In Afro-Caribbeans or Black Caribbeans, again, also immigrants, about 29% experience obesity. And then I have to move my people over here. And then the New York City US born Black population, about 36% experience obesity. So you'll see there's a heterogeneity within the Black population in New York City when you tease it out by those three major groups. Okay. So Africans have the lowest rate of obesity when we compare the two groups. If we then look at diabetes in populations of African descent, you'll see that in the US Black population, about 13% have experienced diabetes. Africans in New York City, 13%. Afro-Caribbeans, 14%, and US born Blacks in New York City, 13%. So here in diabetes, we have a homogeneity within the three groups. And that already indicates that we have some differences in risk profile and some differences in how even something that we think is so strongly correlated with diabetes risk as obesity may not be a really good indicator of risk. And so Africans, 30% diabetes, very similar, no statistically significant difference between the three groups. But for obesity, we have a very stark difference between the group. And again, we also have a difference between the New York City populations and the US as a whole. So this means we cannot apply even findings from African American populations and generalize those for the three groups in New York City. And this was really where all of my research started when I started teasing these things apart to see that there was this significant intra-ethnic variability that had to be addressed and had to be acknowledged. The other challenges we have in diabetes diagnosis is that our current diagnostic gold standard, the OGTT, is resource intensive, it's time consuming, it requires that the patients are fasting, it also requires standard equipment, and it requires blood tests and the processing. We have two diagnostic alternatives to the OGTT that are usually used much more frequently, and at this point the ADA you can arrive at a diagnosis of diabetes without conducting an OGTT, and those two are hemoglobin A1C greater than or equal to 6.5% or fasting plasma glucose of 126 milligrams per deciliter or more. But these two tests actually are problematic in African descent populations. This is a little controversial. I just sat through a talk at the ADA that bashed these ideas, but I'll stick with me because you'll see that there might be some challenges. A1C is impaired by the presence of hemoglobin variants or hemoglobinopathies. It's impaired by G6PD deficiency, and it's impaired by different forms of anemia. And then fasting plasma glucose performs suboptimally. This has been established both in South African cohorts and in other African studies that fasting plasma glucose generally performs suboptimally regardless of glycemic status. And this is thought to be due to low hepatic gluconeogenesis in populations of African descent. So altogether, in African descent populations, when we talk about cardiometabolic risk, we have an increased risk of diabetes, potentially at lower BMI in some groups. We have higher rates of undiagnosed diabetes. We have screening tests that perform suboptimally. And then I didn't touch on this, but we also know that we have significant risk profile variation by sex. So for instance, among African immigrants, men have much higher risk of diabetes than women, whereas among Afro-Caribbean immigrants, women have much higher risk of diabetes than men. And those are not just explained by differences in BMI. As a matter of fact, in Africans, there's an inverse relationship such that men are more likely to be normal weight and overweight and experience diabetes. But that's for another time. We also know that by regarding all Black groups as one, we actually obscure the true risk profiles of all the groups, not just the ones with the lowest risk or the highest risk. And so therefore, this work is really inspired by re-examination. Like, it's time for re-examination and for revisiting why and whether our current screening criteria work. So I'm going to talk a little bit about diabetes prediction equations, which you may know under another name as diabetes risk scores, or they may even be incorporated into some of your electronic health record systems as flagging patients who should be tested for diabetes based on their clinical criteria. So diabetes prediction equations are really mathematical models that are derived from the contribution, or assessing statistically the contribution of risk variables that are associated with diabetes. They are often based on logistic regression estimates that assess or estimate the intercept and the beta coefficients. They can also be based on machine learning techniques and other statistical methods, but I'll stick with the regression estimates for today. Diabetes prediction equations estimate the probability of diabetes. And so by relying on variables, often both non-invasive and invasive variables, so some that require blood tests and some that do not. They're designed to predict diabetes cost effectively based on criteria that we already collect. And they're most often based on population-specific risk. So in prediction equations, you may have variables that are non-invasive, so anthropometrics, demographics, family history. These are variables that we often collect both in the clinical setting, but also in the community setting. And then they also may include invasive variables such as blood tests. So we were curious in our pursuit of identifying screening criteria that worked in African descent populations, or that had been optimized in African descent populations. And this is part of the work that I did, and partly during my postdoc at the NIH, and that I'm continuing at Brooklyn College to continue to evaluate the performance of these prediction equations. So we did a lit review. I won't bore you with all the library details, but we basically went to look to see whether there were prediction equations which included African descent populations, and then to summarize the characteristics and the predictive value of these equations. So we did a scoping review. We worked with a librarian at the NIH, and we found almost 600 publications. But we were interested in only type 2 diabetes and studies that had evaluated statistically the predictive ability by area under the ROC curve, or C statistic, and I'll talk a little bit about later what that is. And they had to be reported specifically in one or more African descent populations. So we ended up with 8 articles that evaluated 15 equations in 5 countries around the world. So South Africa and Botswana, the US, the UK, and the Netherlands. These prediction equations used non-invasive variables that you will recognize are variables that you would typically have from a patient chart: age, sex, race, ethnicity, height, weight, waist circumference, BMI, resting heart rate, smoking status, hypertension, steroid medication, blood pressure, and family history of diabetes and cardiovascular disease. They also used, in some cases, invasive variables, as mentioned before: fasting plasma glucose, hemoglobin A1C, triglycerides, and LDL and HDL. And remember, prediction equations could predict the the future risk of diabetes. So it could be a long-term prediction or a concurrent prediction. So we found the 15 studies, or the 15 prediction equations. We ranked them by their ability to correctly classify diabetes cases versus non-cases. And then we recognized that equations with both non-invasive and invasive variables performed the best. They were the best at predicting diabetes, which might be intuitive, and we believe that blood tests do a great job. So this review was published last year in Frontiers in Endocrinology, and has really helped us move this work forward in terms of identifying the next or the best prediction equation on non-invasive criteria. So now I'm going to talk a little bit about actually testing the ability of one of these prediction equations to identify and correctly classify cases versus non-cases. So we took the top performing equation, which happened to have been tested in the United States in 100% African-American cohort of 1,000 people. This particular equation was developed prior to the ADA adopting hemoglobin A1C as a diagnostic criteria. So the A1C was added to the prediction equation to reflect current criteria. And it had really excellent prediction of diabetes in African Americans. So we took this prediction equation, and then we decided to test it in a cohort of African-born Blacks enrolled in the Africans and Americans study. It's a clinical cohort at the National Institute of Health, enrolling participants who live in the Washington, D.C. metropolitan area, and all of them are African-born Blacks, so Africans who self-identify as Black and who are born in the African continent. So in this cohort, we determined the ability of this equation to detect undiagnosed diabetes, the contribution of each invasive variable to the equation, and the independent predictive value of each of the invasive variables. We had already identified that invasive variables probably were the drivers of this equation. So the study had at the time 451 African-born Blacks living in the US. They self-identified as healthy, so no one had been previously told that they had diabetes. And you can see their distribution in terms of sex, age, and BMI right here. They were primarily from Ghana, Nigeria, and Cameroon, but represent most of the countries in the sub-Saharan African region, as you can see by the colors. We diagnosed diabetes by the OGTT and used a 2-hour glucose of 200 milligrams per deciliter or more as our single diagnosis of diabetes. And in this prediction equation, or diabetes score, we had 9 variables. We had 5 non-invasive, so age, height, waist circumference, systolic blood pressure, and family history of diabetes. And 4 invasive variables, fasting plasma glucose, A1C, triglycerides, and HDL. And this is the equation that estimates the probability of diabetes, where you essentially insert each variable and multiply it by the beta coefficient. So here you see the 5 non-invasive variables: age, waist circumference, systolic blood pressure, height, and family history of diabetes, and the 4 invasive variables inserted into the equation. So we tested the diabetes prediction equation in 4 models. First, we tested the full equation with the 5 non-invasive and the 4 invasive variables. Then in model 2, we tested the 5 non-invasive variables. We retained those in all 4 versions of this model. And we tested 3 invasive variables. Essentially, we dropped 1 invasive variable in each of the versions of model 2. In model 3, we again retained the 5 non-invasive variables, and we inserted 1 invasive variable at a time to the equation. And then in model 4, we tested the single invasive variables by themselves. So first we tested fasting glucose, then A1C, then triglycerides, and then HDL. Our methods were area under the receiver operating characteristic curve to assess the ability to predict diabetes. And area under the AROC curve is essentially the relationship between sensitivity and 1 minus specificity. And then we used the Uden index to identify an optimal cut point for continuous variables. We administered the OGTT to 451 participants, and 7% of them had diabetes, or 30 of them. And when we ran the model 1 to identify how well this prediction equation actually was able to predict which of our participants had diabetes and which did not, it had excellent area under the AROC curve. This was the full equation with the 5 non-invasive and the 4 invasive variables. In model 2, we then tested the equation by again, using the 5 non-invasive variables plus 3 of the invasive variables so that we dropped 1 at a time. And here in blue, you see the curve for the model where we dropped fasting plasma glucose. And the result for that version was that it was significantly lower and it had lower predictive ability. So excluding fasting plasma glucose lowered the predictive ability of the equation. In model 3, we had the 5 non-invasive variables plus only 1 invasive variable. And you'll see here in blue that fasting plasma glucose had higher area under the AROC curve than A1C, HDL, and triglycerides in red, orange, and green. And these differences were all statistically significant. And then in model 4, we looked at each of the variables alone and found that fasting plasma glucose actually had, it appeared, the same predictive ability as the full equation. And again, it was statistically significantly better or different from the predictive ability of A1C, triglycerides, and HDL. And so when we tested the 2, it became obvious or apparent that fasting plasma glucose was really driving the success of this equation rather than having to collect 9 data points per patient. And so when we tested the 2, the full equation and fasting plasma glucose together, there was no statistical difference between their ability to identify patients with diabetes and patients without. And then we went further and said, okay, so if fasting plasma glucose is this good at predicting diabetes, what is the cut point? And this is where statistically we assessed with the Uden index what the optimal cut point was for identifying diabetes versus non-diabetes. And the Uden index identifies the point where the AROC curve is the closest to the upper left-hand corner, which is the optimal prediction, at which point sensitivity is 1 and 1 minus specificity is 0. So when we then dichotomize the equation and the and fasting plasma glucose, we found that the sensitivity of the equation itself was 78 actually, and fasting plasma glucose 100 milligrams per deciliter had a sensitivity of 80 and a specificity of 90. So that's pretty excellent for a screening test, right? That 80% of cases are identified by this, and 90% of non-cases are also identified by this cutoff. So we found that basically this prediction equation could be replaced in Africans by a single measure and one of the variables that was already in the equation. And that's why I said at the beginning that in Africans, fasting plasma glucose could really be a 100 milligram cutoff and maybe an effective diabetes screening tool. And this, we are happy to say, was accepted for publication in Primary Care Diabetes and is in press at the present time. But fasting glucose is a challenge, right? I already said something about fasting measures being a challenge, both in the clinical setting and the community setting. And so what else can we do? Well, there are non-fasting measures of glycemia, and two of them are hemoglobin A1C and glycated albumin. So A1C is, as you're probably all super familiar with, glucose irreversibly bound to hemoglobin. And similarly, glycated albumin is glucose irreversibly bound to albumin. And these two substances present another measure of glycemia. The problems, as I've mentioned earlier, is that A1C is affected by hemoglobin variants or hemoglobinopathies, also G6PD deficiency and anemia, among others. But there's opportunities to use glycated albumin as a new test in Africans because it's not affected by red blood cell issues, and it is still a historic marker of glycemic control. So in this study, we actually worked with the same cohort, except we had fewer participants for this section. But we worked with the cohort to predict diabetes by A1C by itself, glycated albumin by itself, the two glycated proteins together, and then we looked to see if we could create specific cut points for Africans. We used the OGTT for diabetes diagnosis. We used the usual assays for A1C and glycated albumin, and then we used the same statistical methods as in the previous study. So when we tested this cohort, which as you can see was slightly smaller, we had 370 participants as opposed to the 451 in the prior study. Of those, 68% had normal glucose tolerance status. 26%, or 95 of them, had prediabetes, and 6% of them had diabetes. When we took the 6% with diabetes, or the 24 cases with diabetes, and looked at their A1C values, and this will illustrate to you how A1C is truly challenging in Africans with diabetes and without. When we took the 24 people with diabetes, we found that 17% of them had an A1C value that would have otherwise been categorized as normal. 63%, again, of Africans with diabetes by the OGTT had A1C values that would have otherwise been classified as prediabetes. And only 21% of the 24 cases, or 5, had A1C values that were classified as diabetes. So there was a discord between the OGTT result and A1C. And this illustrates that at the standard threshold of 6.5% or above, the sensitivity of A1C is only 21%. So the question is really, is there a cutoff or a specific threshold for Africans that potentially is different? So we ran the area under the RC curve again and found that it was 0.79, which is not great, but it's okay. And then we statistically assessed the optimal cut point by Uden index for A1C, and in this case, it was 5.8%. So significantly lower than the standard criteria. And when we looked at the sensitivity of this cutoff, it was 63%, which is a significant improvement over 21% of the usual cutoff. Then we had been tasked with looking at glycated albumin as a potential predictor. But there are no standard thresholds for anyone. And so we were tasked with proposing an African-specific threshold in this cohort. So we ran the area under the RC curve. The ability of the area under the curve was 0.74. And the optimal cut point was 14.05, which is largely meaningless because we don't usually use glycated albumin in the clinical setting. But what we found was that at this cut point, the sensitivity was 67% for glycated albumin, and the specificity was 75. But what we also found that was if we combined the two and said a patient had either A1C above the cut point or glycated albumin above the cut point or both, the sensitivity increased to 83%. And so by combining the two and lowering the cutoff for A1C, we were able to suggest that this could be used as screening criteria, as these could be drawn from the same blood test. So these three illustrations of things that work somewhat, some things that work better, and challenges in diabetes screening criteria, I of course have some future plans, and those involve really envisioning effective screening and early diagnosis of diabetes. And that goes for Africans living in New York City or Washington, D.C., or other places around the world, and certainly in the sub-Saharan African continent. So what does the next phase look like? Well, we have a project that we are in the process of launching that consists of physician interviews. I'm a big proponent of knowing what is actually going on the ground before making grand announcements. So I would like to understand, especially among physicians who see patients of African descent, Afro-Caribbeans, Africans, and African Americans, what are their current screening decisions? How do they screen? Who do they screen? Who do they decide to screen? And are they using current screening criteria, or are they incorporating some of the knowledge that we have around the performance of both A1C and fasting glucose, et cetera? Also, we want to understand if there are sex-specific foci, or are practitioners actually screening differently among men and women? And I mentioned earlier that African men are at greater risk. We're also looking to validate in population data or electronic health record data the ability of diabetes prediction equations to identify those who are at risk for developing diabetes and those who should be tested. And also to look at whether fasting glucose at 100 milligrams per deciliter actually works in the clinical setting, and whether it should be tested as a tool for referral. And then last but not least, this all is really to acknowledge the history of risk criteria and the origin of the risk criteria that we are currently using. And to acknowledge that our current screening criteria were established in predominantly white populations. And it's really time for us to act on this knowledge to establish screening criteria that are representative of the populations we serve. And to benefit from the diversity of the New York City population, we have a unique opportunity to collect the data and inform future clinical practice, and thereby address health inequities based on non-representative populations. So New York City is really the epicenter of the ability to collect data and collect adequate data to make recommendations and to illustrate the heterogeneity of risk in populations of African descent and other minority populations as well. So with that, I want to thank you for your time and your attention. I also want to thank my collaborators, both at Brooklyn College and at the NIH, especially in the NIDDK Institute, and all of the participants in our studies. And I'd be happy to take any questions.
That was great. Thank you very much. I think I will open it up. So if anyone has any questions that they want to ask about, you can unmute and go ahead. If not, well, while people are thinking, I have a question for you. So you mentioned as part of the future plans, you know, looking at screening within the clinical setting. Do you think that's, I mean, what about population screening? Like, what is your thought on the best places to kind of get at that undiagnosed diabetic population?
Well, yeah, what's the best place? So I know there's, well, we do a lot of screening, right? There's a lot of community-based screenings for diabetes and hypertension. I think and so that network, we don't necessarily have to create a new network. I think the screenings could potentially be that we collect different data. And one of the things that we have, the team at the NIH actually has worked diligently on is to recognize and get recognition for the fact that something like waist circumference and BMI, just like for other ethnic populations and other immigrant populations, those cutoffs are not actually appropriate for immigrant groups. And so I think if we could pair up with current screening programs that take place, but collect maybe more, how do we say, more elaborate data, or just a few more data points, I think that would be a way to get at it. And then also simply to use the electronic health records data, or work with physicians to look at and collecting data at in their practices, to just get a critical mass of data, so to speak, to look at what do patients look like. We don't have a lot of data actually, even in EPI, on what is the waist circumference for populations. We have BMI, but much of it is based on self-reported height and weight. Could we get a critical mass of data from a sort of a passive data collection? I hope that answered your question.
Yeah. I've often thought about how the EHR could be leveraged in this way, but as you know, like the race data is very difficult, and getting heterogeneity within those is something that we're just not sort of able to do very well. But any other questions?
Yes, so thank you so much for such a great talk. This is Lu Hu. I'm an assistant professor at NYU School of Medicine. My work focuses on diabetes in Chinese immigrants. So your talk is very of great interest to me. I have two related questions. One is, I think the issue that you talk about with African immigrants is quite relevant to Asian immigrants in terms of they have a higher diabetes risk in terms of at a lower BMI. So I'm even thinking about the same issue in terms of the cutting point for A1C and the fasting blood glucose. So my first question is, in terms of that fasting blood glucose level at 100 milligram descent, I don't know how to pronounce that, I'm sorry. In terms of that, do you think is that a one-time can be used as a diagnostic tool, or it has to be repeated measure? The reason I'm asking that because I'm thinking about my own fasting glucose level last year when I went to see my PCP. It's about 100. So I'm thinking, wow, like, should I be concerned about that I have diabetes, but actually I don't have that diagnosis. So I'm interested in your thoughts, like, does it a one-time thing, or is more accurate to do a repeated measure to think about it's a diabetes diagnosis? And then the second is, I don't know about in African culture, but in Asian culture or in Chinese culture, usually when people are in a relatively healthy status, like people when they don't have any diagnosis, people usually don't have a PCP. So I'm wondering, how do you engage those people? I'm thinking that those undiagnosed rate in this relatively healthy, like they don't have diagnosis, they probably don't seek care they don't have their PCP in the first place, and they don't seek care particularly as well. I'm thinking, how do you engage even those African immigrants in your prior studies, which is relatively healthy population?
Right. Okay. Two really important things. So thank you for those questions. So 100 milligrams per deciliter, we're not recommending it for diagnostic purposes, but more that it indicates a potential diabetes risk or future risk. So it should only be used as a screening tool, but confirmed or by 2 independent tests. I think now the ADA says that it could be 2 tests from the same blood sample, but that it is it's a referral. It's a screening tool potentially. But I think that the key piece is that the 100 milligrams is, I mean, who knows what's going to happen in the future, but it's been identified in other studies around the world that in some populations, 100 milligrams fasting can be consistent with an elevated 2-hour in the OGTT. And so in low resource settings, or in settings where you do not have, as you mentioned, primary care physicians, either in immigrant communities in the US or globally, these screening criteria could be helpful in identifying people in a community setting to then be referred for a clinical setting. And then your second question was about how do we find the people who are undiagnosed if they don't have a PCP, or if they don't access regular care? That's a really good question. In my work with the African immigrant community in New York City, there's actually a fairly high compliance in terms of seeking medical care, not necessarily a PCP, but seeking clinic care. There's at least 2 clinics that I'm aware of that see patients of African descent without insurance, so they get free care for and part of the reason is to ensure access to medical care and regular care. But I think what I would like to move towards is that we figure out ways to identify in the community setting, so in a non-clinical and sort of the non-threatening setting, we identify people who should seek care. And so we have been using BMI. You also mentioned that, yes, the BMI cutoff should definitely be different. The waist circumference should also be different. But that we establish some screening criteria that then could identify people who then should be referred for care. So I think there is a sort of a stepwise approach, and that could work in multiple settings, both low resource settings globally, but also in low income immigrant communities in the US, that could facilitate that access, and also could work hand in hand with health insurance programs that could ensure that people get the care, but they also get the health insurance that ensures that they can actually maintain the care.
Thank you. Thank you so much for your great talk. Really enjoyed it.
And I agree with you that we have to, it might actually benefit if we did like a multi-ethnic study that could sort of illustrate, okay, these are the general risk profiles for these different groups, and that we could save time and effort, but we could also really illustrate the diversity and risk characteristics in the different populations, but also the things that are shared.
That's one of the great opportunities of living in New York, right?
Right, exactly. And I think we have a unique opportunity in New York City to do that because we have a critical mass of so many populations. The argument typically in epidemiological studies is that there weren't enough participants in this group to warrant separate analysis. And I think that New York City gives us that. I'm hoping.
Yes, totally agree.
And we have this, just one of the things that Earl, Margaret, and I, and Jeff have talked about was using the New York City CDRN, the Clinical Data Research Network, to see if we could explore some of these concepts and see what data we can get together. And one of the big challenges, as everybody knows, is this race ethnicity stuff. And you know, it will probably, in order to do this, will probably take some more innovative methods, kind of to, the clinical data, for instance, we know that's there. That's not the problem, right? It is the race ethnicity, and we might need some, you know, other techniques to kind of bucket people. And but you know, so this, we really do have a big opportunity to do this. I wanted to ask Judy just to comment a little bit. I don't know if she's still on. Yeah, because Judy, you've been doing this for decades. What's your perspective?
She's there, but she's muted. I don't know if she's
Yeah, I don't know either. All right. Well,
yeah.
I mean, just Margaret, I don't know if you know Judy, but Judy's been doing this for a lifetime.
Okay. I should know her.
Yeah.
Well, I think you're right, Paul, that we need to, I've been thinking about, like, how do we establish, and this we would do, you know, in a sort of machine learning approach, is that we would establish phenotypes, and we could potentially establish those without having the, we might have the race data, but we may not have ethnicity or origin, right, or people, immigrants, were they born in the US, but we might be able to establish a phenotypic profile that is independent of where people are from.
Right. Yeah. Let's, Judy, are you able to comment?
I didn't catch everything that she said because I'm getting my sound back up. I had to run in to do something on Zoom on something else for a while, so I'm going to have to listen to your entire talk. But I didn't hear the last thing you said. I just got back.
Wow.
So would you repeat the last part of, because you were talking about people of African descent in various places, but I didn't hear exactly what you said.
Right. So Paul had talked about the opportunity of using New York City electronic health record data to explore different profiles, risk profiles. And we know one of the challenges is that we do not necessarily in that type of data have, we may not have reliable race data, but we certainly will not have reliable data about immigration history, or so whether people were born in the US or not, and certainly not where they were born. But my suggestion was that we could look also at phenotypic profiles, which could be constructed from some techniques I would have to learn, but some machine learning techniques that would allow us to sort of, and Paul used the word bucketing, people that we could identify specific risk profiles that we might be able to establish without knowing where people come from.
I like the idea of trying to do that. I think we have to be very cautious in what words we use. At one word, the word profile was a negative word. I think we've gotten beyond that. But the one word which you wouldn't be using from the machine learning is admixture. The word admixture brings up all kinds of negative community, but I think profile is okay now. It wasn't 10 years ago.
Right. But I think now, these days, I think the word phenotype is sort of that might be.
Yeah, and what we can do is a little survey to find out, informal survey to find out and get basically community input in terms of, but I love the idea.
Okay.
Yes, I just want to share that in our study, we actually ask, were you born in US? And if they say no, then we follow up with which country were you born in? And then we also ask how many years have you lived in the United States? And then maybe another suggestion to CDTR, because I think right now at NYU, we have a center focused on study of Asian American health. We have a pilot grant opportunity each year as well. And then I think in that opportunity, they require each pilot awardee to collect those uniform data set, like where does these participants come from, like across all the funded pilot study, they requested that. So maybe later they can do a pooled analysis of some sort. Maybe CDTR can require pilot awardee to do the same, like a common data elements across all the funded research, something that we can do as well.
That's a great idea.
Yeah. What is?
Do metadata, right? Couldn't we just get a bunch of studies and smush their data together?
Yes, absolutely.
Okay.
Right. And NYU also has the Black Men's Health Study that probably at this point has a significant chunk of participants. And I'm pretty certain that they have the origin data as well.
Yeah, I think so. I think they ask origin data. Yeah, country of origin.
Right.
I mean, this becomes interesting because also, so you know, once you could see where the electronic data is, you know that a lot of the other, so the people have done research, and so they will have they'll know demographics, but that demographic won't be in the electronic record, and so you could get that from them, then you could apply it to what you find in the electronic record to be representative of that entity that's doing that. So there might be real, you know, clever ways of kind of bringing together data sets.
Right.
She's had to run out again, but I'm back again. And actually, she talked about data sets, and I hope I'm not out of line because I missed part of the conversation, but the SOUL database, I think, could be a very good one. And then I have a cross-sectional database of 2,000 Chinese immigrants where we have a very detailed history of where they grew up and how many years they were in different parts of China. If we had wanted to look at the effects of the famine in terms of that, but it turns out famine was nationwide, so it was a given time period, didn't matter where you were in China. But actually people from NYU have used that database. So we could compile databases from different places, because I think the methodology that you've proposed for looking at people of African descent applies across, and New York City has any racial or ethnic group is not homogeneous that immigrates to New York.
Right.
Well, I'm asking all this because I also know that the CDTR is putting in a renewal proposal, and this might be something that could go in as part of that renewal.
I was thinking exactly that, and Earl's smiling because he's doing the population health section for that.
Yeah.
Well, so Earl, we just wrote it for you. and you have your collaborators here, right? Lou can do that, and Margaret can do that, and you can do that. I mean,
because I think it's a methodology that would be wonderful to share with other folks, because I think, in fact, I just reviewed a manuscript where they did a whole thing about people from the US and people from, I think it was Cyprus. and a Mediterranean diet. But what they didn't do is look at acculturation. So the two populations blended together, and I couldn't figure out without some more information what they were really trying to look at.
And you know, I mean, part of this could be there could be a whole theme like this about testing out alternative methodologies, right? Because that's really the challenge here. Because
methods then we get community input on how we should look at it, because we think we know how to look at it, but they may have other ideas. So I love the mixed methods idea.
With big data, and Earl knows that I've been on the case to do big data, that the small stuff is just boring.
And actually the center at NYU does a lot of community engagement and getting qualitative, so it gives us mixed methods in terms of big machine learning and community input either by interview or focus group.
And Nadia Islam was on the FANIC board with Margaret and I at the same time.
She also is a faculty member of the CDTR.
Margaret, it just comes full circle, doesn't it?
We are a small world. New York may be one of the biggest cities, but we are a small community in New York.
That's very exciting. Yeah, so very, very exciting. And I think there's opportunities to, and Paul, I'm supportive of your big data idea that we don't have to look at one group at each point. Like, it doesn't have to be a separate paper. I think we really have an opportunity to examine and potentially create recommendations or propose ideas to consider for screening, similar to how the BMI criteria got shifted for South Asian and Asian populations. I think we're ready for a paradigm shift like that in other criteria as well. But we need the data. So.
Well, right, and so we needed yes, exactly, and we need to do that. But you know, I think that I don't know, Earl. You know, you have a naturally occurring collaborative group here.
Yeah, very exciting.
Old networking and the nods that people are now starting to do. They're starting to look at the way they look at social network nods. You can do that with manuscripts, people who publish in common.
Yeah.
Oh, right.
Vanderbilt CDR has it built into their website. We haven't done it yet, but there are more collaborations among people than we think.
Right.
Like Lou and I have papers in common before we met each other through the CDTR, through Jeanette Beasley.
Yes, I have been reading Judy for quite a while before I approach her.
That's right. Okay, we are running out of time. So this is great. Thank you very much for sharing your work with us. And you know, this is kind of you know, an ongoing sort of collaboration. So this is great. There seems to be lots of overlap. So we have to continue. And any final thoughts? I think we will wrap up for